Al Cardillo has been in the long-term care world for, he'll tell you how many years, 30 plus. He is currently the president and CEO of the Home Care Association of New York State. He is intimately involved in all of the dealings of the home care industry vis-a-vis New York State. He works with the legislator. He is a promoter of legislation to try to improve the quality of home care. He represents over 300 home care organizations in the state. And with that, I'd like to bring on Al Cardillo. Al.
Lou, thank you so much. First, I really want to commend you and Beth and your entire team on conducting these conferences. I think that they are an important focal point each year where you're really bringing all the issues together, macro and micro. And yes, it is very important if somebody has their pants down and we need to figure out what to do with them, because that's where the rubber meets the road. And I often find in discussions, that's the perspective that's missing, and that's what the reality is. I also want to really commend Valerie. I always feel like I've been to Valerie Bogart University after I've attended one of her sessions. And Valerie, you are truly a treasure in this field. As you were speaking, my mind went to all the circumstances where your work has preserved services, preserved access, and really preserved the intent of the benefits for the population that needs them. So salute to you, Valerie.
Thank you. Thank you, Al. Back at you.
Thank you. So Lou asked me if I would speak a little bit about the future, and really glad to do this. I think this is a very critical time for the field, not only because of what's before us, but really what I think is ahead, particularly depending on how we come together and how we take advantage of this real critical time in front of us. Lou mentioned about our association. We are really comprised of all levels of home care, hospice, managed long-term care. We have consumer-directed plans, waiver programs, and again, serving hundreds of thousands of New Yorkers annually. You know, there are somewhere around 700,000 to 800,000 individuals that, from at least that we know, that are receiving formal services at home across the state. I think very often those in the health decision-making process don't understand the magnitude of what's out there in the field in terms of the services being provided and the overall need, which often dwarfs other aspects of the system. So really, if we talk about the future of home care, and if we're talking about what the status of home care is today, we really have to start with a focus on who provides the care. And truly, the workers in our field, the nurses, physical therapists, social workers, home health aides, speech pathologists, occupational therapists, and case managers, and so on. These are the people that every day have a profound impact on our population. Every day, the individuals are out really working miracles to support individuals at home. Again, we salute them, but we need to maintain the focus on the fact that this is really the backbone of the system, and it's the work that these heroes do that is pivotal to the support of needy individuals across the state. It's also important to see that the importance of the services and the personnel are pivotal to the entire functionality of the system. We know that, you know, back in the 80s when New York State and the rest of the country went to diagnostic related groups to reimburse hospitals, resource utilization groupings to reimburse nursing homes, that the scales were heavily tipped toward reductions in institutional use wherever that might be possible, and that was always done on the promise of ensuring an effective support system underneath it all. And so we know that home care is not just a good idea. It's not just something that's an option. It's really a critical pillar of the entire healthcare system. That is a point that is not only part of the today and the future of the system, but really has to be a point that's impressed upon decision makers as they address issues of financing, as Lou talked about, as eligibility and services, as Valerie talked about, and as we'll go through the critical areas throughout the day today. You know, in the pandemic, it really became clear that as individuals were being directed to high-risk settings, in particular into long-term care, congregate settings, that those settings really were exposing individuals to enormous risk, as well as a situation that was destined for isolation from family and loved ones. We started way back during the surge, encouraging the Department of Health, the governor's office, to consider a focus on care at home on a priority basis. So really prioritizing that in the discharge process and in the referral process. And we kept at that, and ultimately, in testimony this summer, we framed our recommendation as a home care first policy for patients in this state, not only as an option to facility, but for any points across the continuum where home care might be an effective service for a person. And I want to talk about that as we go through and think about the future of the system. Discussions with providers and other stakeholders statewide found that within the pandemic, and since the pandemic, it really has exacerbated very critical challenges in the field. I think most significantly, an exacerbation of the workforce shortage, and with that, the related issues and concerns of worker safety, patient care safety and access, worker compensation, and recruitment, training, and retention to ensure that we truly have the capacity to support the need that's out there and the demand that's there. Secondly, is the severe fiscal impact from the pandemic on provider costs and losses, and we'll have some slides that show that, and it's really been pretty extreme, especially within New York, given the extent of the pandemic here in our state. Increased need and demand for telehealth services, not only for the innovation and the monitoring and the capabilities of telehealth, but also for the efficiency, for the safety of staff, the safety of patients, the overall operational flexibility of the system. Very critical, the need for appropriate recognition of home care's role by those who are making decisions within the system and partners within the system. What we typically find is that there is a real challenge in understanding not only how significant this field is, but really the roles that are played in the care of patients and in the overall functionality of the healthcare system. That happens on an everyday basis, but in the pandemic was really exacerbated. And because of the lack of that, home care struggles with things like ensuring that there's essential personnel designation and prioritization when there's needs for things like PPE, needs for financing, needs for investment, needs related to our workforce. Another area that was certainly very, very critical in the pandemic, and we believe is really an area where we need to continue the focus, is on regulatory flexibility for operations, service, and staff. The system has been through really chapters of structure. If you go back to the late 70s and through the 80s, the 90s, in terms of where we are today, the presence of managed care, changes in managed care, changes in federal and state expectations, we really need to have a regulatory system that makes sense, primarily with the service needs of the patient, and making sure that the procedures and requirements really revolve around how do we best organize and provide services to patients, and how do we really make them truly affordable within a system. And then finally, the need for data. It really has been a struggle throughout to try to have data to best understand not only the impact of the pandemic across the different layers of the continuum, but on an ongoing basis, data that helps assess cost, quality, utilization, impact of innovations, and so on. Data, I think, is a real constant struggle in our field, and if we're going to go forward, we really need to make sure that data is available. So where's the pandemic left us, and where are we positioned? Although the trend is in the right direction, the impact on operations, workers, and services really continues. So in as much as a snapshot will permit, I have some slides to show about where things approximately stand in the system. So first of all, if you just look at the numbers, to understand what do we have in our state in terms of capacity, and this isn't the whole system because I don't have the waiver programs in this or consumer directed. We know that there's statewide presence of those, however. So in terms of numbers, 114 certified home health agencies, which I will point out is a dwindling number. Licensed home care service agencies pretty much firm around 1,400 because there are limitations in terms of what the state is considering. And I'll speak later about efforts that the state is trying to undertake to actually reduce the number of agencies. 42 hospices, 14 long-term home health care programs, and 37 MLTCs. So within that, as I mentioned earlier, there's over 700,000 patients that are served within the home care system in the state. There's over 400,000 home health aides and personal care aides, and that number seems to sort of jump from somewhere around 250 to 4 plus, depending on who's counting and how that's counted. I think what we need to certainly affirm here is that there's several 100,000 people at the aide level working in this state, and they are the principal service provider. 55% of all home care agencies are estimated to have had a negative margin in 2019, and we know that funds were lost throughout the pandemic. So the operating position has actually eroded since then, and I'll shed some further light on that. So let's look at a breakdown of the different parts of the system. So in the case of certified agencies, based on the costs reported to the state, almost 80% had a negative operating margin in 2019, again, worsened in the pandemic with an average estimated negative operating margin of minus 14%. 76% of hospices had negative margins. And for this, I have the 2018 data, but I can tell you it's not going to trend upward for 2020. And the average negative operating margin was 17%. 40% of licensed agencies had operating losses in 2019. So when you think about the state of home care in the future, it's important to look at this and have an appreciation for the working margins of agencies, which means, can you afford to provide the services that are required of you? And then also put in place the programmatic innovations that the system is calling for to take us to the future, and in fact operate along the lines of system goals, which are to avoid hospitalizations, avoid ER, again, improve quality and patient-centered care, pursue value-based care. You can't do that in a world of negative margin. So this shows you the impact of COVID financially. So again, take those figures I just gave you and compound them in a COVID environment. On the managed long-term care side, again, you see a worsening trend in terms of the percent of managed long-term care plans with negative premium income. This is another a slide that's important to consider, because in addition to your overall financial status, these are the number of days where basically there's payments owed to agencies, both pre-COVID and post-COVID. And you can see that if you're already operating on thin margins, you can't also be operating in a situation where you have payment delays and for the services that you're providing and the workers that you need to pay. Now, this is such a pivotal area in terms of workforce. As I said, and as we all know, the workforce is really the backbone of the field. 85% of agencies reported that they have existing structural workforce shortages and that they've been greatly amplified by COVID-19. So not only do you have a situation where individuals have left the field or had to take an absence of the field to care for family members, or because their children were home from school, but you also have hugely diminished capacity to operate training programs to onboard new individuals into the field. Because of the spatial and distance issues primarily, you have programs that have been reduced to a trickle. We worked to propose to the Department of Health an online training program for classroom content while maintaining in-person for clinical. And while the department was very responsive in terms of approving and going forward with that kind of a model, there are so many steps in the approval process. The approvals have come through at a trickle, and we really need the department's support to really open this up and allow this to perform fluidly. You know, I teach at the University of Albany, and I also teach at the Albany College of Pharmacy. My classes have been remote, and I pretty much, and we with the students pretty much pivoted from in-person to online remote, as have nursing programs and other programs. I think we really need to recognize that this needs to move forward. This also is a slide that really shows a sudden decline in the employment trends. You know, and again, this is something heavily reflective of the pandemic. But again, this what you see, the downward trend, is sort of the opposite with where the need trend is going. So let's look at this. This is just on the basis of the population. You see the increasing demographic changes that are going to pose increasing demands for services. But certainly on top of the demographic changes have been an increase, a significant increase in referrals from hospitals with patients of increasing complexity and increasing intensity of need. You know, that means you've got to respond all the more quickly, and the demand for how to staff those cases actually further increases. So that exacerbates the delta between the demand and your workforce capacity. This has also really increased in the pandemic. You know, the fact that 90% of people would prefer to receive care for themselves in their own home. And of course, with the concerns related to the pandemic, that's really opened up again. Really increased in terms of, you know, considerations on whether or not to receive care in a nursing home versus care at home, or in another congregate setting versus care at home. And I think that that's very significant for the corner that I think that we're on the verge of turning. Telehealth is something that also really increased and really surged in the pandemic. I think one of the major points here is that we have a system that prior to the pandemic was, you know, I think home care has been the foundation of telehealth and telemedicine in the state. However, even with the pandemic, what we find is that the operational support for telehealth, both in terms of the active reimbursement within the system, you know, and support for capital that's necessary to run a telehealth program, a lot of that is really not present within the current structure, and active support really needs to be provided in order to meet what is really going to be the growing demand and push in this area. I'm going to go past these slides, and let's talk about what's next. I know I'm going a little bit quickly, but I want to be very conscious of our time. So where are we going next in the system? So home care has been very profoundly impacted by COVID-19. I think some of what we just talked about is indicative of that, and what you know from your work in the field certainly shows it. But I really see home care not only in its resilience during all of this, but really in terms of the focus of where things are, to be really repositioned to be stronger than ever. Here you see, I put the image of a comet. Because, you know, I came into the system, I mean, actually, I don't want to say it, but 41 years ago, I came into the system, and the home care comet was right there, visible, coming around the sun, and it was really at the, you know, at the focus of the state's actions in terms of an intervention that really needed to be supported, and a lot of it is pictured in that man to the left of that, who's Senator Tarky Lombardi. Who, by the way, sends his regards. So the crisis in COVID not only spotlighted the value and importance of home care, but really has been a focus of driving demand to really unprecedented proportions. Right now, the focus on investing in the system, in the home care system, to meet the need is really at a 40-year high at the state level and the national level. And not since the late 70s and the onset of the 80s, when the comet was last around, has home care been so looked to and has really been so positioned. And so with that, I really believe that in terms of our future, that future is now, and the window is open. There's $1.6 billion that was inserted in the newly adopted state budget to invest in home and community-based services, and $400 billion for home and community-based services, which is a proposal now among the federal infrastructure proposals. So with this kind of financial, investment, that's being looked at, and this kind of attention, if not now, when, for home care. We recently concluded our annual meeting, and our conference theme was meeting the moment. So I think for all of us in this virtual forum who are here today because we care about these issues, and across the entire state, home care's moment has really come, and it's come back like that comet, and it's really now. So where do we go? So what I want to really start out with in this next part of my presentation is really this underlying theme of a home care first policy for New York State. HCA supports the adoption of a New York home care first policy that will ensure that home care is the principal option for patients across the continuum of need whenever it's appropriate for that individual, and that aligns the policies, the rates, and procedures to support this option and goal in real terms, not just paper, not just planning, in real terms.
Al, we have
Yes.
about 10 minutes left.
Very good. I think I'm on track. Thank you so much. So I want to go back. So let me go back to the first spin of the comet. This is what's on the books today. And many folks don't realize that the preamble in the public health law to Article 36 states that the legislature finds and declares that the provision of high quality home care services as a viable part of the health system and as an alternative to institutional care should be a primary focus of the state's actions. That was in 1977. Are we back to the future now? Has the focus of home care as a primary focus of the state's actions, not for cuts, as Lou said earlier, but for the proper care and stewardship, is it a primary focus of the state's actions? So that's why we are focusing so heavily on the home care first policy for New York State. Again, we believe that home and community-based care should be a principal option across that continuum. It's overwhelmingly preferred by patients, and certainly amid safety concerns in the pandemic, we can see in press reports, in press conferences, and in other actions, the extent to which the need for home care and the focus on home care is so critical. So we are looking to encourage the legislature to adopt language for a home care first policy. Again, that is more than just paper, that is something that will really align the policies and the procedures and the support where it needs to be. Very, very tied to this is the issue of the home care workforce. You cannot deliver care without a workforce. Our state budget appropriates $1.6 billion for the workforce, but with details to be determined. CMS just published guidelines that provide very wide parameters for how states should implement their funds, and the $1.6 billion is actually comes from an increase in the federal Medicaid percentage that's going to be available to New York. So there are parameters and terms associated with those dollars. The governor's office, the health department, folks are looking at that. But again, there's no direction in the budget in terms of how these dollars are to be allocated and used. We're looking for a principal role, and I would encourage all stakeholders to be looking for a principal role to maximize the flow of those funds as a beginning investment in what we need to align the structure of the system to the demands and the needs. Additionally, we have language that we had circulated during the budget and that we are promoting after the budget to actually create a better statutory structure for providing funds that support worker compensation but that also provide key occupational support, transportation, childcare, career ladder, mentoring, the kinds of things that are really critical on the job that make this job very, very difficult, make this occupation difficult, and also to recognize that we need to target shortage regions and shortage disciplines. It may not be that the needs may differ by region or by discipline and region, and we want to make sure that there's an ability to also be able to customize intervention so that it really responds to the need. So if you're in Hamilton County or Essex County or Westchester or Long Island, we're able to, and providers are able to customize how the funds will support an active response. I mentioned earlier that the state is looking to reduce the number of licensed agencies. Well, when the licensure law was created, it was specifically created with a prohibition on the state controlling the number of agencies based on an arbitrary need methodology. And that was really because the licensure law is about trying to ensure quality and regulation and not to regulate numbers. It was to really protect the consumer and have a structure in place. So a year ago, not only did the state add that dimension, but the legislature approved a proposal by the MRT to actually allow the health department to produce a request for offers to have every licensed agency come in with an application, and then in some way the health department would determine which agencies could continue to provide services and which agencies would be discontinued to provide services. Again, there's basically there's no parameters, no guidelines, with that, and so you now have the legislature actually doing a relook at this with legislation by Assemblyman Gottfried and Senator May to actually repeal that RFO. I would really appeal to those who are concerned about the capacity of the system that to really join in the effort to call for this repeal, because we have no idea how this would impact agencies with long-standing relationships with patients and workers with agencies and so on. And if there is a desire to look at how our capacity aligns with what our need is, that's fine. We believe that the state can study those objectives and have a more a specific and concrete plan than basically give a blank check to decide which agencies will and won't stay in business in the state. The same was some of this was experienced with the RFO related to the fiscal intermediaries that were the RFO that was published last year, and then ultimately where there were selections made on FIs, but greatly reducing the number of fiscal intermediaries involved in the consumer directed program. The legislature amended that in the budget to provide for further flexibility to maintain FIs. We believe there needs to be further flexibility still in that language so that quality organizations are not arbitrarily limited from the field. Telehealth. So even though home care has been the foundation of telehealth in the state, the law that was originally the landmark law in the country for telehealth in 2007 is fairly restrictive on how telehealth can operate within home care. And while that's been opened up in the pandemic, when the executive orders go away, we're concerned that there is not equity in the capabilities of providing telehealth, as well as equity in terms of the reimbursement for telehealth and home care. So we have legislative amendments that would not only address that, but also the more actors you get involved in telehealth, the more you have the really risk of refragmenting the system technologically. Because so we don't want individuals with 5 different organizations that are all trying to do telehealth with patients and really not coordinating, really for there not to be a proper recognition of, who does what and what makes sense for patients. So we think that there could be some useful guardrails in that process. And then there's an additional array of legislative initiatives that we put in motion or that we're collaborating on that we think would be very important. One is legislation that would ensure better stability in home care by stabilizing the rate structure. If we had time, I could go into details of explaining how out of date the current rate structure is with the realities on the ground. We think that it's important to maintain COVID era regulatory relief. We've been working with the Office of Mental Health for several years on creating collaboratives between mental health providers and home health agencies and home care agencies so that there's a full integration of physical and mental health services for individuals residing in the community. The governor signed a bill that we developed with OMH to include home care in the geriatric mental health demonstration program. And now we have an additional bill that we're trying to get through that will provide for flexibility. We have legislation that would incentivize collaborative models to address healthcare disparities. We certainly saw in the pandemic, a lot of this was laid bare. We believe that providers working together sort of as a safety net and with a common purpose can go much, much farther in addressing disparities. And then two other items that you see on the list, one related to making hospice services more accessible by allowing individuals in assisted living to participate, and also to support home care workers when they park, to have a spot to park to visit with their patients. These are some critical regulatory areas, and I'll finish up in a slide or two, Lou. These are areas that are critical within the regulatory realm that are really occupying a great deal of focus. One is permissibility of nurse practitioners and physician assistants to be able to order services. You know, up from time beginning until now, you know, you need a physician's order. However, the state over the years has adopted regulatory changes to allow nurse practitioners and PAs to do it, but it was all contingent on federal authority to allow these other practitioners to be able to order home care services. The federal government made their changes last March and April. New York has still not cleared the way to ensure that nurse practitioners and physician assistants can order these services, and we're waiting for the finalization of a state regulation that will align authority at the state level with the federal level. There are many reforms, and Valerie talked about them, that relate to the independent assessor, that relate to increases in eligibility, physician prior approval. All of those things carry major implications for the system, and these are things that we will continue in our own advocacy to try to ensure that if they are implemented, that they're implemented in a way that's really most workable for patients and providers in the system. Just going to go down here to one last. So I'll just do this in 60 seconds. Federal advocacy areas. This is, again, an opportunity for us to be able to really work national attention in support of the home care field. And that ranges from recommendations on how best to design and support home care through the $400 billion program that the president has proposed. I can tell you, not since the early 80s has there been a federal focus on home care of this magnitude. Telehealth support at the federal level, particularly under Medicare, is really critical. Homebound flexibility. Many of you know that the Medicare edge for eligibility for coverage of services is very sharp as it relates to the homebound requirement. While the federal government provided flexibility in COVID for COVID patients, we believe that that same flexibility should be extended. This is flexibility around the home care limit, the homebound limitation should be extended more broadly to Medicare beneficiaries. We believe that that would be a major improvement in Medicare coverage and in total coverage for home care, and support both patient goals and Medicare goals. And I think the last slide that I just will reference here is that home care is repeatedly excluded from major federal healthcare reform legislation such as the ACA, the HITECH Act, and we believe that Congress and the White House should create new and specific authority to invest in home care innovation the same way it's invested in medical innovation and innovation in the hospital side. So I'll stop right there.
Al, thank you so much. So much information, so much to digest. We're going to have, bring Valerie back on, have a little discussion, and if we can, get a couple of questions before we take our coffee break for the morning. The there is a dichotomy. We have an office in Manhattan, Long Island, Albany, New York. We go up to Lake Placid. We serve up to the Canadian border. There is a tremendous difference between applying for home care services in New York City and applying for home care services in St. Lawrence County, rather. There just aren't agencies. All the issues that you just raised, Al, upstate, and this is most of upstate now, down through the Hudson Valley. Used to be just up north of us. Now it's down Columbia, Greene, Dutchess, Ulster. Tremendous shortages, and you call a home health agency and they just can't staff the case. And Valerie, in New York City, I think there are still enough aides being hired by agencies to fill most of the needs. Is that still true?
No, COVID has really, it's what Al said. COVID has really changed it. We in New York City had never seen worker shortages before. And we always thought it was an upstate problem and a Long Island problem. It is a New York City problem now. We have especially live-in cases, even split shift, which used to be a very attractive sort of schedule for an aide. No, we see a lot of problems both in MLTC plans, also services authorized by HRA through immediate need.
So there's a program, Al, that we use, Consumer Directed Personal Assistance Program, the CDPAP program, which can allow families to find care. And sometimes it's family members, sometimes it's neighbors. That program for the last 2 years has been under attack. It faced budget cuts. There was litigation. Where does the state stand right now on CDPAP?
Well, if you part of that, what I was addressing in the whole discussion of the FIs, the fiscal intermediaries which administer the program, the focus of the state has really been on diminishing the number of fiscal intermediaries, and then and again, the tug back and forth with the legislature is that the legislature is concerned that the RFO process that the state used to condense the number of fiscal intermediaries was overly restrictive and has basically put some of them, at risk of closure. And we're very concerned about that too. So that's really been a major focus. I think one thing that's really missing in the state's plan, and this has been the case for the past number of years, is where do you view the future of the structure, utilizing consumer directed and utilizing traditional home care? How should these two parts of the system align, coordinate, and what is the vision for where the state wants the workforce and the service capacity to come from? I mean, it should not be accidental. It should not be arbitrary. I've been in meetings with Brian O'Malley, the director of the CD Payne's Association, many times pointing out that it's the state's lack of investment in the infrastructure that puts additional pressure on the consumer directed program to sort of be the solution when really you need a more balanced approach.
You force people into a situation where, and let's face it, people hire people not through CDPAP, but they're paying privately. A lot of them are paying off the books. They're paying in cash. They're finding people who don't even have a green card, and they're providing care to them. So there's a whole black market of home health care in addition to that issue. But Valerie, there used to be a wonderful concept, and I love the name, money follows the person. Whatever happened to that concept?
So I think isn't that the open? I think in New York State that's the Open Doors program.
Yeah, there's all these wonderful programs, but they go unfunded.
Right. No, I don't think New York opted for the particular brand of it, right? That I think Ann Halleck was working on like 25 years ago.
Yep.
Right. But CDPAP is our alternate program, and we see families pressured by plans and local districts. If you want care, you have to do consumer directed. And it should be a choice. Not everybody wants consumer directed. Many people need the added services that a licensed home care services agency brings, and hiring and training and scheduling. And, it's not for everyone. It's an option. And it's when you look at the statistics, like upstate, it's used so much it's very uneven around the state.
Yeah,
You can
guilty as
see
charged.
where,
We use it all the time by necessity because you cannot get an agency.
right,
I've had this in my own family.
right,
I was a caregiver for my uncle. I couldn't find an agency to provide care. We had to build a team through CDPAP. That's the only way we could do it.
And Lou,
right.
I think that goes to the point of the current 1.6 billion that's in the state budget and the 400 billion at the federal level. It's like, and the whole home care first mantra, if you will. If you want a home care system that works, you've got to be prepared to invest in that system, both in the standpoint of recruitment and training, but also in the compensation of the individuals that are providing this kind of care.
Yes.
And that's the case certainly at the aid level, but it's also the case at the professional level. If home care agencies are competing with hospitals, nursing homes, insurance companies for nurses and other therapeutic staff, if they can't pay them competitive rates for what is really an incredibly challenging job, it's very, very hard to maintain your workforce. And in a situation where there are layers and layers, hours of documentation every night. And I think that goes to looking really at this in a coordinated way to make sure that the policies make sense, because that's the way the programs really need to operate in a sensible way. They need a sensible environment.
Yeah, I think we have to reimagine the whole system. And you and I have had conversations about how care in the home can be done differently. And certainly my belief is that technology has to be part of the solution.
Yes.
And we have to automate home health care. Never going to replace the hands-on care, but hands-on care can be done so much more efficiently, better, and perhaps with less volume if they're supplemented with appropriate levels of technology. And that technology is available in the marketplace today. So on June 4th, the conclusion of our program is a gentleman who's developing an app in home health care. And we're going to hear from Al Evans on June 4th what is going on the technology side of this. But the whole system and the financing system has been a patchwork quilt for so many years, and it's just layer upon layer upon layer without ever really breaking it apart and rationalizing all of the different financing systems. We haven't even talked about the insurance yet. We'll do that on June 4th. What role does private financing play in all of this? So these are all great issues. Valerie and Al, thank you so much for being with us this morning. And Valerie's going to be back with us later in the morning to be part of that panel. And there have been a lot of questions posted to the Q&A. We're answering them as quickly as we can. I know Valerie has been on answering some of those questions as well. And again, we will be answering all of your questions. Post them to the Q&A. We will get that compendium out as quickly as possible after the conference.